Hello, everyone. I think we'll get started. So we have a small interested group, hopefully. So you guys know all about allergies. You don't need to go to that other session. If you don't, I'll just give you the 3 drugs you need. No, I'm teasing. So I am excited to have you here. We want to talk to you about things we think that will take you a little further in thinking about kids with lung disease and thinking about pulmonary. And so hopefully this will be a positive experience. We know it will be. So I want to start by recognizing our faculty. So I'm Robin Dieterding. I'm from the University of Colorado. I'm professor of pediatrics. I'm the chief of pediatric pulmonary and sleep medicine at the University of Colorado. Elizabeth Fiorino right here is from Hofstra and Northwell in New York, and she is an associate professor. And then John Poplar is with us from the Atlanta Healthcare Group, and he's been the medical director of inpatient services at Scottish Rite and the co-director of the primary ciliary dyskinesia service. So we have, and both of these individuals and myself have been very involved in thinking about kids with rare disease for some time. So we're excited to talk with you today. So this is a CME session. So there's CME provided. I'd like to thank the Boehringer Ingelheim company for providing this educational grant that was awarded to the French Foundation, who is providing the CME for this event. There's a QR code that further explains the CME opportunities for you to understand. And so we'd like to thank both of them for allowing us to present this information today. And so these are disclosures. Here's our disclosures. I have a few disclosures and Dr. Fiorino and then Dr. Poplar. So with that, I'd like to start talking about what we're going to do. We're excited to bring this to you. Again, our idea is talking about the burden of children with interstitial and diffuse lung disease, really through the framework of rare disease. We're going to talk about pulmonary medicine, have you think about that. Child diseases, which are these rare diseases, new ways to think about child diseases, when to refer, when not to refer. We have a nice session, which has a lot of teaching points in there. We have some patient cases, and then we'll end thinking about your roles in the medical home for taking care of these kids. So we're excited to bring this to you today. And so our objectives will be to recognize the prevalence and the burden of children with interstitial lung disease among pediatric patients. Have you be able to formulate a plan that describes the steps for early identification of these children and the potential for referral to subspecialists. And then think about strategies in the medical home that you can help families with education and communication to improve their care. So that's what we'll be bringing to you today. So this is a conversation about rare disease, but we also want to take this as an opportunity to talk to you about the evolving field of pediatric pulmonary and why it's important. You all know these are the most common conditions you see in your office are respiratory conditions. Acute bronchiolitis is the top reason for children under 5 years of age to be hospitalized. Respiratory failure is one of the top 5 reasons for children under 5 to be also hospitalized. And pneumonia and asthma are the top 3 reasons for children 1 to 9 years of age to be hospitalized. So breathing is a very common problem. Those are common problems. We're talking about rare disease on top of that. But why is breathing so important? You do a lot of this in your office, but why is it such a problem for kids? It's because they're at a mechanical disadvantage with their breathing. Yes, their airways are small, but their compliance of their chest wall isn't very good. So that means that when they go to take a deep breath in and increase their tidal breathing or the amount they breathe in, their chest wall collapses. So they have multiple mechanical disadvantages related to their chest wall, the airway size, that puts them at risk with all of these other conditions that we just mentioned, including rare disease. Unfortunately, over time, the predictions of climate change and what's happening, exposures of forest fires in the West and ozone with increased heat exposure in the South, environmental exposures are increasing such that These are going to also aggravate respiratory conditions. And the one thing we like to talk about is really lifelong lung health really starts in childhood. And so we all have very important jobs to do to maximize pulmonary health during childhood, because once you get to a certain age, it plateaus, and then in adults, you start aging. So we're all kind of the guardians of the lungs for kids to allow them to have lifelong lung health. And then the good news is there's so many different new medications, new advances that really can help us support that improvement in lung health and lung function. So breathing is important. There's exciting new advances coming forward to think about that. They're common problems and they're rare problems that we're going to talk about today. So I'm going to turn this over to Dr. Fiorino to keep going.
Thank you. So this graph is pretty new, but it sort of encapsulates one of the reasons why I went into pediatric pulmonary medicine. So I'll just walk you through it a little bit. The different colors, like the different shades, see if I can get this pointer to work. Okay, so the different colors, the pale blue refers to antenatal and super early childhood. The yellow is childhood. The green is adolescence. And then the red, I guess this orange, is sort of what happens from early adulthood, about 25 years of age and on with aging. This is meant to demonstrate sort of maximal lung function. So the green curve is sort of an ideal healthy development. And you'll see the dotted lines kind of branching off a little bit. I don't know if any of you guys watch Marvel. I've been watching Loki with my son, and this reminds me of branching timelines. But okay. Anyway, so a couple of things I want you to pay attention to. So this lung function plateaus at about 25 and then starts declining. If you have an insult in adulthood, you'll decline. If you reach a lower plateau, that decline is going to have a bigger consequence. And the optimistic news, though, is this sort of bigger dotted line represents catch-up growth. And we can have a big impact in childhood. I lost my pointer there. Well, in the yellow part, we can have a big impact in childhood. We can have a little bit of an impact in adolescence as well. And so really trying to figure out where we can diminish kids' exposure to risk factors is really, really important. But also knowing that if a child has something that's sort of predetermined to genetically determined low lung function, they are going to follow a reduced trajectory over time. This demonstrates a similar concept, but it's specific to child and specific to a specific patient. And this is actually looking at specific pulmonary function values. So the blue is vital capacity. It is sort of all the air that a patient can breathe out in a spirometry maneuver. The yellow is FEV1, what they breathe out in 1 second. And then the red is FEF 2575, which is really goes along with the small airway function. And sort of a similar concept, lung function increases until about the age of 25 or so, and then goes down. The important point here is that if you reach a lower plateau, similar to the other similar to the other graph, you are at a higher risk for losing more lung function over time, poorer quality of life, increased early mortality. So going back to the concept of rare disease. So what is rare disease? So the definitions in the US, disease that affects fewer than 200,000 people. In the EU, a disease that affects less than 1 in 2,000. Important to know, which I probably don't have to tell you guys, 70% of rare diseases begin in childhood. 70 to 80% are genetic in nature. And collectively, rare disease affects up to 8% of the population. So even though individually rare disease is rare, when you put everything together, it's not so rare. So in our population, cystic fibrosis and sickle cell are probably the most commonly known rare lung diseases. But in children, there are many rare lung diseases. So this term, child, which you've heard us talk about already, children's interstitial and diffuse lung disease, is really an umbrella term. It's not a specific diagnosis, but rather it's a term to describe a really broad range of a lot of different conditions with high morbidity mortality. They're really over 200. So it's really hard sometimes to think about and conceptualize, and especially to study, because there are so many conditions under this one umbrella. But the important piece is that they do share some common features in presentation and do share some common features in morbidity and mortality as time goes on. The key biggest thing is that in order to make the diagnosis, you have to think about it. And again, collectively, they're more common. So these is because each individual category is so rare, these disorders are out there and they're seen, but they may not always be recognized, not only by primary care providers, but also specialists. And child can be present at birth, which affects lung development, or it can develop at any time over the lifespan. And genetics, again, are expanding the number of diseases, giving us reasons for presentations, and also allowing us to classify them better, to target treatment better. And again, we'll say this again, diagnosis is really important because child disorders affect lung function in childhood, and therefore that maximal lung growth and lung function that you can see in adulthood. So why is early recognition important? So early recognition can lead to a sooner specific diagnosis, which, and again, we're sort of at a very exciting time right now because, I don't know, even like 10 years ago, we really only had sort of an empiric therapy and expert consensus. And now, because genetics is allowing us to understand underlying etiologies, and also with advances that you'll hear about, we can actually administer appropriate therapy that specifically targets what's happening with the child and really change the trajectory of what's happening with them, leading to improved outcomes. And sometimes that's actually giving a therapy that's going to address the underlying issue. Sometimes it's actually not giving any specific pharmacologic therapy, but really making sure that we provide nutrition and allow them to grow, because the pharmacologic therapy may not help. So when do you suspect child? So think about it in terms of these, if 3 of these 4 are persistently present in the absence of a known disease. So if a patient has cystic fibrosis, if a patient has ciliary dyskinesia, and this is one with a little bit of a caveat, if a patient is born premature with BPD, that one is a little bit of a gray area because sometimes those children can have a child diagnosis as well. The important thing is if it's out of proportion to what you expect, think children's interstitial lung disease. So respiratory symptoms, so what the patient experiences, cough, shortness of breath. Respiratory signs, things that we see in the patient, retractions, tachypnea, digital clubbing, hypoxemia, and then importantly, diffuse abnormalities on imaging. So we have guidelines that were published by the American Thoracic Society that give us a really useful framework. The guidelines specifically address the population ages 0 to 2, but this framework is also really applicable to older children as well. So imaging. Imaging is really useful, specifically chest CT, to really characterize disease patterns. And we're going to talk about this a little bit later as well, but this can really help us to even start thinking about a differential diagnosis in etiology. It's really important that when a CT scan is done, it is performed at a center with pediatric experience, both to minimize radiation exposure of the child, which is something that we consider, but also really to optimize image quality. If you have a wiggly baby, you're going to get a very fuzzy image. So it's really, really important. And then again, we're going to talk about this a little bit later. There are new criteria for pediatric radiologists to describe fibrosis, which is different from fibrosis seen in adults. Evaluation of oxygenation. So this is a big one. I know pulse oximetry is not always done, but if it's done and it's normal in a child who's awake and at rest, that doesn't necessarily mean that it's normal all the time. It may be abnormal when they're sleeping. It may be abnormal when they're exercising. An echocardiogram. Pulmonary hypertension is a comorbidity associated with chronic lung disease and can be associated with a risk for mortality. Bronchoscopy with bronchoalveolar lavage. So this lets us characterize anatomy, look for infection, look to see what kinds of cell populations are in the lung, and sometimes make a diagnosis. genetic testing is something that has really changed our practice and really, again, helped us to classify diseases much more specifically. There are panels that are available, and then also whole exome and whole genome sequencing. And then lung biopsy is not done all the time, is still the gold standard of diagnosis to classify the histopathology. For urgent or severe cases, it's often very important. So this is what I was alluding to before. So radiology may actually now suggest the diagnosis. There are very specific patterns that go along with parenchymal fibrosis, growth disorders. I'm not going to read all the diagnoses here. You'll hear about them. And this may actually help us to guide our diagnosis. I actually had a patient from the NICU in whom a CAT scan was done, and the radiologist, in their interpretation, they actually listed suggest evaluation, suggest genetics for interstitial lung disease, and they were right. So that actually came from the radiologist. So this is a nice diagram that really kind of outlines in a very simple way the stepwise approach to the child diagnosis. So in the primary care provider's office, the first piece is thinking about suspecting ILD. And that, I hope, as we go through the cases, you really sort of start to think about when should I really be considering this? Doing a clinical evaluation and also a really detailed family history. Some of these conditions will often run in families, genetic conditions especially. And then starting with considering a chest radiography. When they go to the pulmonologist, we'll do more evaluations, like thinking about CT scan, thinking about bronchoscopy, thinking about which kind of genetic panel or testing, often in consultation with our geneticists. And then depending on the result of the rest of the studies, thinking about bronchoscopy and thinking about lung biopsy. Okay, so now I'm going to hand over to Dr. Poplar.
Thanks very much. Okay, thanks for being here, everyone. So I'm going to try to split this apart a little bit, just as Dr. Fiorino said, give you a framework for when to suspect certain disorders. And the way we've split it apart for now is by age. So the first set is to really consider the kids who are under about 2 years of age, or things that may present in the newborn nursery or the NICU. So this would include neuroendocrine cell hyperplasia of infancy, or NEHI, surfactant dysfunction mutations, surfactant disorders, and then alveolar simplification, lung growth disorders. And then in the middle, there are child syndromes that present secondary to exposures, infection, inhalation injury, radiation injury. That can really be present at any point in the timeline or at any age. And then for older kids, we do see a pretty fair number of disorders that are associated with systemic disease, autoimmune mediated lung disease, vasculitis, systemic sclerosis, et cetera. And we'll go through those a little bit later. So when we think about alveolar simplification and lung growth disorders, the way that we consider these are issues where the alveoli and the interstitium are not formed appropriately, and they're not really doing their main job, which is to provide oxygenation and ventilation. And you can see on this histology where the alveoli look very enlarged, the interstitium does not look normal, the septa also look abnormal. We tend to see these sometimes in association with congenital heart diseases, chromosomal anomalies, so not uncommon in trisomy 21. It can present with premature infants. We do often see vascular changes in addition to these abnormalities as well. And there's not an insignificant amount of mortality associated, but also can lead to quite a bit of long-term morbidity in terms of chronic supplemental oxygen use. Other invasive ventilation may be required. Pulmonary interstitial glycogenosis is one of the more common types of an alveolar simplification or a growth disorder. We don't really tend to see this after about 14 months of age. And this is a developmental disorder where there are abnormal cells within the interstitium, which I'll point out. This also is associated with congenital heart diseases, trisomy 21. There's a very characteristic chest CT that you can see here with ground glass opacities and cysts throughout the chest CT. I'm not pointing correctly, but anyway, I won't belabor that. And often gold standard diagnosis was with lung biopsy, although now if you have a patient who has a pretty consistent clinical picture and a consistent chest CT, you can make the diagnosis or at least have a hypothesis about the diagnosis. This is called pulmonary interstitial glycogenosis because there are very clear cells within the interstitium. And if you look at the electron micrograph on the top left corner, there are glycogen stores within those cells, which are where the name comes from. There's not a overall therapy that we go to, although typically there's a trial of prednisone or methylprednisolone to treat. And this is typically done in conjunction with the treating team and the consultants. It's not without risk. So the most common disorder that we see in the younger kids, and one that likely everyone in this room can see, is neuroendocrine cell hyperplasia of infancy. So this is a disorder where children present with marked tachypnea, retractions, and are often hypoxemic. They can kind of be an insidious presentation. So I often get referrals where it's just for tachypnea and there's not really other thought about what could be going on. But the family has noticed that this kid, unlike their other children, breathes very fast. The pediatrician has noticed it, and so they get sent our way. So I was going to say when I was a fellow 10 years ago, but I think it's more like 15 years ago. But anyway, when I was a fellow, this diagnosis was mostly made with lung biopsy. However, since then, there is a clinical score that's been developed where you can actually score what symptoms or these patients have and what signs are absent. And then depending on the score and a characteristic chest CT, often you can avoid biopsy. So when we look at this clinical scoring, you get a point for each sign or symptom that are present, and the signs and symptoms that are in orange, if they are not present, you would get a point as well. So classically, there's crackles, hypoxemia, tachypnea, retractions, and sometimes a pectus excavatum. Then there should be an absence of clubbing, typically not significant wheezing or persistent wheezing, and really no chronic cough. Sometimes you'll see these kids have failure to thrive or decreased weight because they're so tachypnic and retracting so much. They're using so much energy with their breathing. Similarly, there's a very characteristic chest CT that goes along with this. So the chest CT on the right has ground glass opacities in the right middle lobe and lingula, kind of like a bat wing distribution. And that's pretty classic for knee high. There's also some air trapping apparent on this chest CT, kind of a mosaic pattern, which is also very common. So if you have a kid who has pretty consistent clinical findings, and then this chest CT, most of the time, we would not proceed to lung biopsy. There is a very characteristic lung biopsy pictured here, where when you stain it with the correct stain, you'll see an increased number of neuroendocrine cells, and they typically are much larger than you would see on a non-knee high lung biopsy. But as I said, a lot of the time, you can make the diagnosis without biopsy. So I practice in Atlanta, which is a growing population. And so there are NICUs really all over metro Atlanta. So it's not uncommon for us to get consults requested from the NICU for patients who are born potentially full term, who have respiratory failure really out of proportion to gestational age. And so when we get consults like that, we start to think about surfactant mutations. So these are a set of disorders where the production of surfactant is altered, which really leads to much less surface area that's available for oxygenation and ventilation. The three classic disorders are mutations in surfactant protein B, C, and ABCA3. And then there are a couple of additional disorders, mutations in NKX2.1 gene, and that has a little bit of a different presentation. Some of those children are very affected with abnormal thyroid studies and sometimes chorioathetoid movements. And that used to be called brain-lung thyroid syndrome, fairly rare. And then mutations in CSFR2 A and B, which often presents with pulmonary alveolar proteinosis, which is essentially the alveolar macrophages cannot evacuate surfactant from the pulmonary space. And so you get these very characteristic CTs. So the top CT is from a child with surfactant protein C mutation. And you can see the blue arrows. There's some cystic areas. There's ground glass opacities throughout the entire lung field. The image on the bottom is what's called crazy paving. And this is a patient with pulmonary alveolar proteinosis, where they have a mutation where they're not evacuating the surfactant. And so you get a very characteristic chest CT. Often for these, so again, when I was a fellow, there were lots of biopsies done. There are now genetics panels that can pick these up. And so sometimes now we're not getting a lung biopsy, or at least we're sending the genetics panel if we think it's a consistent clinical appearance and waiting for those results to come back. And then just moving to some of the older kids and kids that can present at any age. So bronchiolitis obliterans is a very common child disorder that we see, and often comes to us initially from being referred from their primary care physician. So these are kids who have chronic wheezing, prolonged expiration, but really out of proportion to what the inciting insult was. So this is really a final common pathway to a lot of different insults. So it can be post-infectious, it can be from an inhalation injury. These are sometimes kids who have an autoimmune disease, who have had either a stem cell bone marrow transplant or a potentially lung transplant. And this can be really across the spectrum of age. The cause of this is obliteration of the very small bronchioles. And it may be a little hard to project, but when you look at the CT, so there's very differential expansion of the lung fields. There's often air trapping. And then when you look at the spirometry, and I'll just read it off if you can't see it. So the FVC and the FEV1 in this patient are significantly obstructed. So particularly the FEV1 is 27% of predicted. And for these kids, it would be pretty unusual to have a kid with just chronic wheezing that's just not responding to any therapy coming in with such significantly obstructed pulmonary function testing. This is a path slide that just shows that really the destruction of the bronchiole, all the cellular debris that's been built up, and all the injury that's occurred within the bronchiole. And then for older children, this is not an exhaustive list. And some of these we co-manage with our rheumatology colleagues, but certainly we do see some of these issues with lupus, mixed connective tissue disorder, granulomatosis with polyangiitis. We do consider kids with diffuse alveolar hemorrhage syndromes as part of the child cohort. We sometimes will see kids with autoimmune diseases, inflammatory bowel disease in particular, and then certainly children who have immune dysregulation disorders. So common variable immunodeficiency, some of the other immunodeficiencies that we see will present with this. And then I'm going to pass it over to Dr. Fiorino.
Okay, so we talked about classifications based on age, based on exposure, and then based on systemic disease. Now, this is sort of another way to think about it too, that kind of crosses over all of those categories, which kids are at risk for pulmonary fibrosis. And you'll hear later in the talk, it's exciting because now we actually have something that we can do about it. So there are multiple different conditions that confer risk for acquiring pulmonary fibrosis as time goes on. You saw Dr. Poplar talk about some of them. So the surfactant dysfunction disorders, environmental exposures, pleuroparenchymal fibroelastosis is a condition often associated with patients who've undergone treatment for high-risk neuroblastoma. You heard Dr. Poplar talk about transplant, both stem cell transplant and lung transplant, and then immune-related disorders and genetic disorders. So the key again is recognizing that the child has this disorder, and then understanding about monitoring them for fibrosis as time goes on. And again, I alluded to this earlier. This is new for pediatric radiologists to have definitions for pulmonary fibrosis on chest CTs. Some of the findings are common between kids and adults. Let's see if the pointer works. Okay, there it is. So, reticular abnormalities, traction bronchiectasis is here, sort of where you see some dilation of airways kind of pulled by the stiff lung. Architectural distortion, you can see this huge cystic structure here. The lung doesn't have a normal appearance. Honeycombing, I mean, imagine the appearance of a honeycomb with all these sort of round shapes. And then different for kids are these things called cystic lucencies. So different from honeycombing, you'll have these areas where it actually projects a little bit better on our screen, where you'll actually sort of almost see underlying lung here, but they'll be in a cystic shape. And sort of putting everything together, a radiologist can actually begin to diagnose pulmonary fibrosis in a kid, which really was not the case before. Lung biopsy is the gold standard for fibrosis. Using a trichrome stain can help really clarify that. The interstitial spaces widen and that worsens diffusion. And you can see sort of in this high power view, especially, sorry, I pointed at Dr. Poplar by accident. So you can see anywhere that appears blue, that's widening the interstitial space. And you can imagine easily how oxygen really can't get through that blood gas barrier. So again, now that we have CT scans, even though I love looking at lung biopsies, we can often spare kids the morbidity that often may go along with a lung biopsy. So this is a question that we would like you to answer. Still text, which is of the following best describes patients affected by children's interstitial and diffuse lung disease? So A is children only with no residual effect in adults. B is children with at least one of about 12 respiratory genetic disorders that present in infancy. C, children with at least one of more than 200 rare diverse respiratory disorders. D, children with lung diseases having ground glass opacities on high resolution CT. Or E, children with pediatric lung disease related to autoimmunity. So think about it and pick the best answer. Like we're taking our boards, the best one. I hate those multiple choice questions. Okay. So this one, the best answer is children with at least one of more than 200 rare diverse respiratory disorders. But I would argue the bottom four all describe some facet of child, but the number of choice C is really the best answer. Okay. Is this me still?
I think so.
Okay.
This is a post-test question.
Okay. So this one, answer this one. You've seen this one before. Again, log in. The following children are seen at your clinic for respiratory problems. Which of the cases would lead you to suspect child? So a newborn, 2 to 3 months premature with shortness of breath. A 1-year-old born at full term with tachypnea, poor growth, hypoxemia, and no diagnosis. A 3-year-old with an asthma diagnosis. A 6-year-old with 3 cases of treatment-responsive bronchitis over 6 months. All right. Almost everyone. Okay. So most of you picked B, the 1-year-old born at full term with tachypnea, poor growth, hypoxemia, and no diagnosis. And that is the answer that we agree with most too. Again, sort of this is the one where the theme is really out of proportion. Not necessarily, especially last year, unusual for a 6-year-old to have 3 cases of a lower respiratory tract infection over 6 months. 3-year-olds can have asthma. A premature infant is going to have shortness of breath when they're born. So that really that 1-year-old who has these prolonged symptoms is the key. So I'm going to give this back to Dr. Dieterning.
Well, we tried to give you a baseline. I know some of this sounds very rare, but we think that over time, you may hear some of these cases and really want to give you a framework for how to think about this. But now we'd like to do a few cases with you. So this gets to be more interactive. And the first case is really these kids who have recurrent or prolonged bronchiolitis. And we know, we see this in the hospital, we see this in the hospital service, we know this happens in your practice, so we want to talk about it. So this would be an example of a child who was a term infant, exclusively breastfed, but at 2 months of age was admitted to the hospital with RSV bronchiolitis. and had hypoxemia and crackles, treated with supplemental oxygen and had some feeding issues associated with that. So had an NG placed and was sent home for follow-up in the medical home. However, at 3 months of age, they were readmitted with increased work of breathing, low oxygen, and crackles. Supplemental oxygen was started. Again, pred burst was given, and now this time they couldn't get off. It was they were discharged on a ½ liter via nasal cannula. Now you're going to see these green headers that appear. These green headers are reinforcing areas that we think should at least stimulate a discussion with pulmonary or referral. So now you've had a child who's had 2 admissions for bronchiolitis. In my camp, that's too many. That gets a pulmonary evaluation. But in this case, 4 months of age, they were referred to pulmonary because they could not get off oxygen. So this is a classic example of this is way out of proportion. This is not pursuing or following a typical course, post-viral infections. The other history relevant to this was the child started coughing when they were drinking and continued to have a problem since admission. This time at the pulmonary office, their SATs were at 86 on room air. They needed a ½ liter to keep them elevated. Child had tachypnea retractions and was breathing 80 times a minute, subcostal retractions and crackles in all lung fields. How many people would refer that to a pulmonologist? Yep. Good. Well, that's where this child ended up. So what in this case would contribute to the suspicion of child? A, that the child was hospitalized at 2 months of age for RSV bronchiolitis. B, supplemental oxygen was needed at 2 months with RSV. Or C, prolonged hypoxemia that followed an RSV infection. D, the need for prednisone burst. Or E, persistent pattern. What would you say? What would be the one that would give you most suspicion? There are probably 2 answers here. Okay, so there are children who are going to get admitted for RSV bronchiolitis, and if they're 2 months of age, it may not be uncommon. So that one might not be the answer. If they have a severe case of RSV, supplemental oxygen would not be a surprise. However, if they have RSV and they can't get off oxygen, and that is a prolonged episode, that would be a problem that would require referral and would be suspicion. Prednisone, people use that like water, so I'm not sure what that indicates all the time. And a persistent pattern, though, that also could be consistent with the diagnosis. So in this case, prolonged hypoxemia following RSV infection that doesn't go away, though a persistent pattern, you could say that's the same thing. So I would agree with C and D. Good job. Well, let's think about what's the differential. Actually, this is, we view this almost every week that I'm on service. So what's the differential for recurrent bronchiolitis? And what studies would you order? And so again, the green is when you might consider referral. So think about what your differential is, because we go through this all the time. You can get 1 episode of bronchiolitis, 2 episodes. I think that's too much. And so the differential in an infant for recurrent bronchiolitis is aspiration. They do not have to cough. You don't even have to get a history that they're coughing and choking. That is actually a common one. Recurrent bronchiolitis, okay, they could have bad luck. They could have pneumonia, that's true, but they could have had a bad pneumonia, but in general, that's less common. Congenital heart disease, hopefully we pick that up early when they've come to your office. And that's no longer an issue, but you have to think about it. So it's in the differential. An airway abnormality, yes, but they should be noisy. There should be something happening. And then this diagnosis of child. And quite frankly, in our environment, that's not working very good. Okay. Aspiration and a child disorder are really some of the most common things to think about. So this is 101 on the hospital service. So chest x-ray was ordered on the child as it should have been. It doesn't project well, but there was peribronchial thickening, which is very nonspecific, and some air trapping. So the diagnosis does not come from the chest x-ray, though you could rule out congenital heart disease and certainly pneumonia by getting that. So in this child, we're going to show you the workup in a second, but it brings us to having us think, like, when should you refer to specialty care? Severe respiratory symptoms, persistent symptoms, out of proportion. You're going to hear this all the time. Like, this isn't right. We can't figure out why they're breathing so fast. Why can't they get off oxygen? This isn't what we expect. Comorbidities, like there's a combination of maybe this child's aspirating, they have an airway problem, they have a sleep problem. So if there's multiple comorbidities, that's a good referral, and persistent X-ray changes. So these are all reasons and when to think about at least calling your friendly pulmonologist. In this case, our patient had the following evaluation, and most of them were normal. Then in conversation with pulmonary, a CT scan was done, but this would be the evaluation. So which of the following should a pediatrician include in a workup for suspected child? So this is you again, like, what would you do? This is now a post-test question because we asked you about this previously. And based on what we've talked about, what might you say? Bronchoscopy or lung biopsy in A, B, family history and whole exome gene sequencing, C, family history and pulmonary function testing, D, high resolution CAT scan and swallow studies, or E, pulse oximetry and chest X-ray. Could be more easily done that you would do, or that most medical homes should do. Okay, the majority of you said pulse oximetry and chest X-ray. We would agree. Oxygen, oxygen, oxygen. Thinking about these kids is really important. It's a fifth vital sign. Chest X-ray can be helpful to rule things out. So we would agree that that's a fairly common thing to do. Bronchoscopy and lung biopsy, pulmonologist is going to do that. Family history and whole exome sequencing. Again, usually pulmonary's got very specific panels they're talking to their subspecialty teams with. Yes, family history for sure, and pulmonary function testing. You may do pulmonary function testing in your office, and that's right with spirometry, but some of these kids need more complete pulmonary function testing with lung volumes and diffusion capacity. So it depends upon the age of the child. And then, yes, you can order a CT, but I can't tell you, depending upon the center or where you get it ordered, if it's a poor quality, we're going to be repeating it. So it needs to be thought about, ordered. Many especially centers have ILD CT scans that they have protocols for, and then the swallow study, you could definitely order those. So the best answer for sure, 100% of medical homes we think should be doing pulse oximetry and consider chest X-ray. And in this case, based on what Dr. Poplar talked about, this was an example of a child that had knee high. 10 out of 10 and a CT scan, this would be classic. This disorder is very common. This and aspiration we think about. And why it's important is because these kids may need oxygen for a while. And if you don't diagnose it, they keep being admitted and admitted and admitted. And so it's nice to understand what they have. We treat them symptomatically, but we're able to manage their oxygen needs. So this is a case of a child who had persistent pulmonary symptoms and would be referred. These children can be quite ill. They can be hypoxemic, they can be crackly, and there's a persistent of findings which you would have referred for. The diagnosis was made on clinical symptoms and CT scan. And the medical home is important here because this family is going to rely on you to do their pediatric care, their growth. You're going to be watching it with the pediatric specialist because we're not going to see them as often as you do. And then the subspecialty care referral is really for severe symptoms, recurrent admission and persistence. And the medical home, these families really need you because most people do not know what this is. And the pediatrician becomes so important in these kids because you need to help people understand this kid doesn't need to be admitted. This is what they have. And so many times the families appreciate their pediatricians who really, they do the bulk of like talking to the school with a specialist to make it okay to need oxygen for prolonged periods. So we're going to get you even more active here. This is a session we're going to say to refer or not to refer. And we're going to have you raise your hands or not. So this is what you would do in your practice. And then we're going to provide some teaching points behind these cases as if you were in our clinic that we would do teaching around. So this is going to be kind of rapid fire about how to think about these cases. So let's do the first one. So would you refer to a child specialist or not? So this is a 6-year-old full term, but the growth's only at the 3rd percentile. They occasionally cough, but they're very active. They're doing everything they want to do. You do a pulse oximetry because it's the 5th vital sign, and it's low normal, but it's in the normal range. But you listen to the chest and it's normal. You don't hear anything. And the chest x-ray, you get a chest x-ray, kind of what we talked about. And there's some faint interstitial markings, but nothing very specific. Who's going to refer to this patient? Or are you just going to watch? Who's referring? Who's not referring? Who's sleeping? No. And who, maybe referral. Okay, maybe. All right. So let's talk about some teaching points. We would say this is a very subtle case, but I agree with you. Maybe is the answer, but we would have a low suspicion to refer. And this is the reason. These are some of the teaching points we talk about all the time. Growth is the red flag here. A kid who can't grow, even with BPD, we're worried about what their oxygen is. It can be a subtle finding that the lung disease is a little more out of proportion than you might think. Occasional coughing, no coughing should happen. I guess with allergies in that other session, maybe, but no cough should really be ongoing. The chest exam can be normal. I can't tell you how many, I wear, that stethoscope around my neck, but how many times I don't hear anything and they still have pathology. So that does not rule it out. And low normal oxygen, when you see that, you have to say like, okay, so I'm in Denver. Like, so normal for us is 95, but if I see a 93, that's low normal. I'm thinking this kid's not going to be normal at night or if they walk. And so you check it because it's important. And then if you have something abnormal on a chest x-ray with other symptoms, that kid's really begging for a CT scan. So these would be things that we think about, even in these subtle cases that you have to ask yourself what's going on, and you guys can take the next step. What do you guys think? I mean, we see kids like this all the time.
Yeah, and I think the growth, like you said, is concerning. And if you had a kid who maybe had some coughing and maybe had this chest x-ray, you might think, I feel like we're just thinking 99% of the chest x-rays I order have this increased interstitial markings. But if the child is growing normally, that's one thing. But if you have any abnormality and they're not growing, then that's something that you need to investigate a little bit more.
I think all the signs and symptoms I could explain away except the poor growth, and that tips that over the edge. And I think the low normal oxygenation, I mean, we have a very busy sleep lab, so it does not take much for me to put a kid in the sleep lab or at least get an overnight oximetry study if I'm just kind of doing a screen, but that would be worrisome to me.
Yeah. Okay, next.
Okay, so this is a 7-year-old who's doing fine, but you note that he has a history of cancer in remission. And in taking the history, his treatment regimen included radiation therapy to the chest. So who would refer this kid for further pulmonary evaluation? And who wouldn't? And who might? So this is a kid who's at risk because of exposure. Now, not every child who is exposed to radiotherapy develops pulmonary fibrosis, but every child is at risk, and radiation pneumonitis can happen early on or can happen later. And the important thing is, these kids sometimes will not give you any clues in the history. Sometimes you don't realize it until you actually do the pulmonary function test and you see that it's low. So just remember, pulmonary toxic chemo, radiation therapy, stem cell transplant are all risk factors for child. So this patient needs regular monitoring with pulmonary function tests, including plethysmography, which is lung volumes, and diffusing capacity, and oxygenation, however you decide to monitor it. So again, even if the child is totally fine, I've definitely seen kids who've been in remission, and then 10 years later, even they develop something that maybe you would have been able to intervene had we diagnosed it earlier.
Yeah, I would. So we in our center often we really highlight plethysmography, but sometimes these kids get to us because the oncologist will order plethysmography without us seeing them, and then we'll notice that it's abnormal and then send them to us. So for those of you who do spirometry in the office, I think that's very helpful. But at least, every few years, these kids need some total lung capacity and diffusion just to make sure that nothing's being missed. And it can be very insidious.
Yeah, you guys are so important because they have all these long-term follow-up clinics from these kids with cancer, but kids fall through the crack and they don't go and they get lost. And then they appear in your office. And so asking them if they've been followed up, has this been the case? And they don't even have to, kids can walk in and have 50% lung function and say, I feel great. What's wrong with you? And so you become very important in getting these kids back into follow-up.
Next one. So this is a 13-year-old with a history of bronchopulmonary dysplasia, fairly asymptomatic since they were little, but now presenting with increased work of breathing with activity, some dyspnea, some wheezing, somewhat of a modest response to albuterol clinically. Any takers for referral? Referral? No? Maybe? So we would love to see this patient, the royal we globally. So a huge part of our practice are former preemies and kids with bronchopulmonary dysplasia. And the majority of them do great. They move through the practice, and after a few years, we're not really treating them as aggressively. But we do have a number of kids who come back to us with very similar story. They can have persistent obstructive lung disease. There's quite a bit of tracheomalacia and bronchomalacia associated with prematurity. Sometimes that becomes an issue later on. Sometimes these kids do have impaired airway clearance. So these are also kids that we follow pulmonary function testing in. Low threshold, there's quite a bit of debate in the literature, but low threshold for inhaled corticosteroids. We treat them with bronchodilators. So we do see a fair number of these kids.
So another one. So this is a 12-year-old accomplished athlete. They develop shortness of breath and cough, which lasts 10 minutes after activity. And they've borrowed an inhaler, and it helps if they take it before exercise. So is this a kid that you would refer? Yes?
Mm-hmm.
No? Maybe?
Mm-hmm.
So maybe. So if this is sort of pretty standard exercise-induced bronchospasm, everyone's comfortable with bronchodilators, the insurance plans aren't making you get prior authorizations for albuterol, then, and the child improves, and it's pretty clear, then yeah, this is totally something that, that can be taken care of in the pediatric medical home. But if there's sort of anything different, or if the child doesn't get better, or if the child is having other symptoms, it might be nice to have sort of a full set of breathing tests. But definitely trialing albuterol pre-exercise definitely and if it helps, that's great.
So this would be a 12-year-old. Now this is an athlete, but now all of a sudden he can't get up and down the basketball court. Or maybe we'll make it a she. She can't get it up and down the basketball court without really huffing and puffing. And there's lip discoloration. So people think the lips are turning blue and albuterol does nothing. Who's going to refer this kid? Well, okay, that was a good one. So we would agree with you because the risk here with color change, this child could have pulmonary hypertension, which could be insidious in its development, could have severe asthma that you're not really picking up, could have other development and developing cardiopulmonary issues. So this would be a child that would need referral with imaging, pulmonary function tests, and probably echocardiogram in what's happening with some exercise testing if we can't figure it out. So definitely a referral for this patient. So any questions about those? Have you seen those kind of cases in your office? Are there any questions about some of the teaching points?
You mentioned high-res CT.
Yeah.
You to leave other imaging modalities, sound, MRI.
Who wants to take it?
So I wish that ultrasound was super helpful for defining child. I mean, that would be great. Not yet. MRI, and that's an interesting question. There's stuff in the literature now about different protocols looking at diffuse airway or like heterogeneous airway disease like bronchiolitis obliterans, but also looking at other forms of child. It's really research based at this point, but hopefully at some point. And yeah, I mean, I think the key thing is like getting an X-ray and sort of looking at it, and even if it is sort of minimally abnormal, knowing that on CT scan you can still see pretty significant disease. I mean, it's tricky because it's like the CT is a little bit of radiation, although I feel like it's gotten much better. It's like I think at our hospital it's like 25 chest X-rays now, maybe even a little bit less.
Like 5 maybe at our institution. So that's why the big children's hospitals will really dial back the radiation dosing. And MR, it's getting better, but it takes a very expensive inhalation of a gas. Most institutions don't have that yet, so it's evolving. I think with pneumonia, I mean, there's different consolidative lung lesions that ultrasound's coming along, but it's a good question. But I think there's so much pattern recognition right now with CT, that's still the modality.
I think ultrasound for the BPD population and graduates of the NICU, I think that's going to be the evolving modality. There's been quite a bit of literature now over the last few years between neonatology and pediatric pulmonary groups looking at that. So I think that's where that'll evolve. I don't know as much for child per se.
Any other questions? Yeah.
Without really knowing the symptoms, and actually need something that can get more. At what age would you, in the pulmonologist degree, to follow the patient in the clinic, at what age would you do the CT to look for Parkinson's?
I would do it then. Sorry.
Mhm.
Okay. I mean, I think at that point, you know, I think I definitely have followed kids who are NICU graduates who have persistent tachypnea and retractions and kind of look like a knee-high patient, except that they were preemies. And maybe I kind of cheat a little bit and give them a little bit more grace. So I'm not as quick to work them up. But I think if it was a kid who from the jump, you know, was late preterm or full term, needed supplemental oxygen and continuing to have symptoms, and they're 3 or 4 months of age, and you know, we don't feel like there's overt dysphagia and aspiration, and I think that's a kid I would start the workup on.
Mhm.
Can we get another 1 or 2 months later, or just call it? You don't have the typical.
It's a good question. So I think this is the kind of kiddo that, you know, we always sit and go, well, who are we going to watch and follow? But most kids, there's a good explanation for why they are hypoxemic in general. I could think on my hand, how many kids we can't really figure out why they're hypoxemic. And so we like our imaging. We like our echoes, we like our swallow studies, we like our bronchoscopies that can really unmask those things. Normally, the CTs will show something. We might not be able to explain why they're showing that, but we can find something on CT scan that can help us explain it away. Other questions? Or
I mean, I
thoughts?
think, I think it's tough because I feel like even reevaluating that first CT is sometimes helpful too, because sometimes people, if they look at it with different eyes, will pick up subtle changes.
Mhm.
And then the other thing is too, in tiny babies, sometimes if there's, like we were talking about before, sometimes if there's motion artifact,
Mhm.
sometimes if the slices weren't as thin, sometimes rarely things can be missed. So I think revisiting that first CT, and then if this child is still on oxygen, I think revisiting it makes sense.
Mm.
You know, and then of course, like after excluding other stuff. So assuming that the child's had newborn screening that's
Yeah.
normal for CF, that the sweat test is normal, things like that.
But that echo for pulmonary hypertension and pulmonary veins, that's really, so really working with cardiology on those situations is important too. Those are tough kids because you get worried about them. So.
I think
Well,
I'm sorry,
ahead,
I was
go
going to say, I at that point, I might be looking more into genetics. There's a couple of interstitial lung disease and diffuse lung disease panels that are commercially available that might help. I would it's outside of child, but I would think about ciliary dyskinesia in a kid who has
Mhm.
respiratory failure or hypoxemia that's really out of proportion to exam. I mean, I think I'd be casting a wider net. And I would consider repeat chest CT, although you hate to do it so quickly, but if it's not acting right, I mean, I agree. It's very unusual to have like, no abnormality that you can really pin down. That would make me a little anxious.
Well, why don't we move on? So we've got 2 more cases for you guys.
You may notice some similarity in these cases, but I think that's why I always say that being a pediatrician is probably one of the hardest jobs to do and terrifies me, because you're seeing all these kids and you have to figure out who is a needle in the haystack, and you're seeing so many kids with such similar presentations. So another 12-year-old, this kid has been diagnosed with asthma. He could never get up and down the basketball court very well, and he develops skin lesions. Is this a kid that you'd refer to a specialist for a child evaluation? Yes. Okay, so this is actually based on an actual patient, like all of our cases. So developed skin lesions like these, sort of on his hands, on his heels. So what's next for a patient like this? So thinking about what are the diagnostic possibilities, a little bit different from the baby who's on oxygen and can't come off. What testing? And again, this is a kid who's older, doesn't necessarily need anesthesia for some of this stuff. And how do we arrive at a diagnosis? So pediatricians sent him to pulmonary. Pulmonary function testing and a CT are done. The PFT shows a moderate restrictive pattern with a low forced vital capacity, as well as a reduced diffusing capacity. And the chest CT shows ground glass opacities, traction bronchiectasis, and interlobular septal thickening. So not as progressed as that other CT that I showed with fibrosis, but still has signs of fibrosis. So what happened? So based on the presence of restrictive lung disease with this diffusion impairment and evidence of interstitial disease on CT with cutaneous vasculitis, he went to rheumatology and genetic testing was performed. And so he had a variant in this gene called TMEM173 that's consistent with sting-associated vasculopathy. And he began targeted therapy. And even though this is a super rare disease, it's a really key example of when genetic testing leads to a specific diagnosis that then can lead to a specific treatment, which is a JAK inhibitor, which can really change the trajectory of the patient's illness. So his skin lesions improves, his lung disease stabilized. He has regular monitoring with rheumatology and pulmonology, and routine follow-up continues with their pediatrician. So how can pediatricians support their patients with suspected child? So when you're at sort of, I think discussing what to expect at every stage is really key. So if you're just referring the child to pulmonary, what happens at a pulmonary referral? And it's going to be different depending on if the patient is a baby or if the patient is an older kid. If the patient's a baby, we don't really do infant pulmonary function testing except for research sort of purposes because an anesthetic's involved. But if you have a child who's, depending on where they go, bigger children's hospitals, when a patient is 3, they'll start to do oscillometry. That can tell you a lot about airway function, like we mentioned before. And really good pediatric respiratory therapists can sometimes coax spirometry out of those kids. Not consistently, but sometimes. If you have an older kid, they definitely will be doing the full complement of pulmonary function testing. You might have someone put a pulse ox on and then have them walk around the hall or have them run up and down the stairs to see what happens to their oxygenation when they're exercising. And then thinking about, are they going to need, parents always want to know, is my child going to go under anesthesia? Is there for that increased risk? So if it's a very little kid, if it's a baby, they may or may not need anesthesia for the CT. If a bronchoscopy is performed, then kids definitely will need anesthesia. And then what might be prescribed? And this is something that might come a little bit later. I think the important thing is we love talking to our kids, our patients' pediatricians. So communication with the referral pulmonologist. Discussing psychosocial stressors. And again, depending on the age, families, if the kid is on oxygen, families are like, am I ever going to be able to go to Disney World? Am I going to be able to fly with my child on oxygen? And yes, there are solutions. If you have a kid who's 5, 6, like, I don't want to be different. I don't want to go to school with this thing in my nose. Or am I going to be able to play sports? I mean, you have a patient who played hockey with oxygen, which I feel like is pretty amazing. So helping them work through these things. And then discussing genetic testing. The urgency in the diagnostic evaluation referral is really determined by severity and associated symptoms. We talked about this a bit before. These are all, again, those red flags: failure to thrive, pulmonary hypertension, how significant the hypoxemia is. If this is a parent who comes in who has clubbing and says, yeah, I was on oxygen for the first 5 years of my life, that's pretty likely that's a genetic diagnosis. And then multidisciplinary care is really the foundation of this, and it's really changed since, especially since genetic identification of disease has really taken off. And so we work really closely in the diagnostic phase with our radiology colleagues. If there's a lung biopsy, our pathology colleagues, depending on the etiology, our immunology colleagues, our rheumatology colleagues, we're probably comfortable prescribing steroids and some other medications. We're not going to necessarily be prescribing biologics ourselves. Those are all going to be in collaboration. And then you see here, there's a whole team of other services as well. But key is regular contact with the primary care team is essential and sort of the cornerstone of this. Okay, so you're referring a 6-year-old with asthma to a pulmonologist based on suspicion of child. Which of the following would help you best support the patient and their caregivers? Follow up with the pulmonologist. You can discuss next steps with the family. Order a thoracic CT in advance of the pulmonary appointment. Order genetic testing. Order pulmonary function tests. Okay, follow up the pulmonologist. You just can discuss next step with the family. And again, it's so important to the families that there's a team behind them. So let's consider another case, Dr. Poplar.
Thanks. I was just going to echo that I take care of a lot of kids with tracheostomies and ventilators, and it's really remarkable what they can do in the community despite having all this equipment with them. So it's usually when I have somebody who's going to be on long-term oxygen, I usually discuss that also, just to put it into context. So we're going to look at another case, one that, again, I think comes up quite a bit. So a 6-year-old with a recent adenovirus illness is now readmitted to the hospital with wheezing and a prolonged expiratory phase. They need to be put on non-invasive positive pressure ventilation. They have a high FiO2. How would you proceed regarding referral or a consult with a pulmonologist for suspicion of child? A, I would only refer if CT indicated the need. B, I would only refer if the child did not respond to inpatient care. C, I would refer immediately, but not for child. And D, I would refer immediately based on out of proportion presentation. I would see the appeal of not referring if they don't respond to inpatient care, but these are kids that we would suggest referral because of the recurrent nature of the illness. And I'm going to talk a little bit more about that. So this is a case of a kid I saw recently. So this is a 19-month-old who gets admitted to the PICU, comes through the ER, gets a viral panel, which is positive for adenovirus. Really looks pretty good in the ER initially, but gets put on high flow. And then because of this is a whole other talk, because of the amount of flow that the kid's receiving, they end up in the ICU where they get treated with albuterol, stepped up airway clearance. ICU decreases the high flow. And then subsequently the kid gets to room air, gets discharged with just albuterol as needed, no requirement for supplemental oxygen at home. Subsequently, a month later, comes into the ED in significant respiratory distress, gets intubated in the ER, is on a vent for approximately 2 weeks, and then fails extubation several times. And it's highlighted in green because a couple of, well, I guess I was going to say red flags, but these are green flags. You get the point. But definitely worrisome at that point, especially looking back when you see what they initially came in with. So because of the difficulty with extubation, this child gets a chest CT. And CT images are fairly suggestive of bronchiolitis obliterans. So there's some bronchiectasis here. So when you look at these airways, the airways are fairly large compared to the vessels next to them. It's a little bit on the subtle side, but I would call that bronchiectasis, or at least bronchiolar injury. And then when you look at this expiratory CT, the areas that are darker are hyperinflated. The areas that are lighter, including here, are areas where there's not great inflation. So this is kind of mosaic attenuation and differential inflation throughout this chest CT. And there's about 700 more images that I could show you, but luckily Dr. Duding stopped me from that. So there's only 2. So this is post-infectious bronchiolitis. really based on the CT findings, this child did not receive a lung biopsy. So bronchiolitis obliterans is really, as we kind of touched on before, it's pathologic alteration of the small airways, typically the bronchioles, but kind of throughout the airway. And this is thought to be an insult to the bronchiolar epithelial cells, and then it results in inflammatory response. And it's likely that there are some pre-existing factors that play into this. So for kids in the developing world who may have poor nutritional status, there are certainly genetic variants that play a role. So there are other influences to this process. And there's a couple of different types that we see. So there's bronchiolitis obliterans after stem cell therapy. There's bronchiolitis obliterans that occurs after lung transplant as part of like graft versus host disease. And then there's this post-viral bronchiolitis obliterans, classically with adenovirus, although really any virus or any insult in a developing airway can cause this. There's a plethora of treatments. Some people use steroids just by themselves. There's some literature about combination therapy. So fluticasone, azithromycin, montelukast. There's a BAMA protocol I found, which is budesonide, azithromycin, montelukast, and acetylcysteine or mucomyst. So a number of different ways to treat this. And then on the right, so there's really supportive care that we recommend for everybody, keeping up with vaccines, maybe expanded pneumococcal vaccination, bronchodilators if we feel like the child is responsive. And often we'll use bronchodilators even in the absence of a witnessed bronchodilator response on spirometry. So if you clinically think that they're responding, there's really not a ton of downside to that. Pulmonary rehab, which can be hard to find for kids, and then really stepping up airway clearance. So if this is a child that on CT or clinically does seem like they have bronchiectasis or bronchial injury, or you feel like there is some element of impaired airway clearance, this is certainly a kid that I wouldn't hesitate to use hypertonic saline, which is pretty readily available. They may meet criteria for alpha dornase, which is pulmozyme. You can still find mucomyst around here and there. Really just depends. They may need some chest physiotherapy. So those are all interventions that you can do, which are fairly non-invasive overall. So we start to think about this in kids who have really persistent symptoms and hypoxemia, really about 6 to 8 weeks after severe bronchiolitis or pneumonia, really that's presenting out of proportion to what we would expect. As we looked at the spirometry earlier, these are often kids that have really significant obstruction. Sometimes it's fixed. I mean, you can make these kids better and they may still have abnormal spirometry several years after they really have clinically improved or this is resolved. So it is important to follow longitudinally. We do think that has some implications for potentially their life as adults, but again, that's a different talk. Clinical course really can vary. I mean, there are kids that require ventilation and chronic ventilation after this. I've had a number of kids who have really needed supplemental oxygen for a long time. We do think these kids are really at high risk for respiratory complications going forward around this insult, and so really benefit from the medical home. One more question. Well, there may be more. One more for me. Which of the following best describes potential care burdens for patients with child? Bronchodilators are ineffective. Patients may need assistance with airway clearance. Patients must be isolated because vaccines are ineffective. Supplemental oxygen therapy will be needed for life. Standard treatment is needed for intercurrent infections. Okay, so we had a little bit of argument about this. So we really focus on airway clearance. Maybe we have a bias because pulmonology came from really cystic fibrosis doctors. So there's part of that. But we really, for many of these kids, they will not need supplemental oxygen for life. Even if the bronchodilator effect is not apparent on spirometry, they may still respond to bronchodilators, even if it's just to improve airway clearance and really stimulate airway clearance. Definitely an argument for standard treatment needed for intercurrent infections, but we really find in this population that a typical bronchiolitis or a secondary infection, a pneumonia that this kid may have later on, actually may need some stepped up therapy beyond just kind of typical treatments, which is why I'm kind of focusing on the impaired airway clearance piece. So as I mentioned, these are kids that probably do need some improvement with getting rid of mucus and airway clearance. I'm going to pass it back over to Dr. Fiorino.
So again, what is the role of primary care in the medical home for these kids? So really care coordination in conjunction with the pulmonologist. And some patients live in metro areas fairly close to their center. Some kids don't. Some kids have to travel a couple of hours, and their real medical home is the pediatrician. So really important. Familiarizing yourself with the multidisciplinary team. So not necessarily just the pulmonologist, but the other care providers who are involved. Keeping track of vaccinations and preventive care. So RSV prophylaxis with nirsevimab or palivizumab until nirsevimab is really widely available. Routine vaccination and cocooning, making sure every family member, every person possible who's interacting with that child is vaccinated. Counseling and treatment regarding environmental tobacco, smoke, and vaping. I mean, this is something that I start to talk to my patients about vaping when they're about 8. So they understand it, they know what it is, and they're looking at me like I really have 2 heads, but because it's normalized to talk about it. And then understanding the monitoring schedule for comorbidities and medication side effects. So even though a lot of these medications are phenomenal and disease modifying, they come with side effects. Sometimes they need eye exams. Sometimes they need routine. They have different immune systems now because of it. Okay, so where can you turn for information? So there are child research networks pretty much all over the world. Many countries also have their own foundations. The US has a child foundation of which I'm on the board, and we really want to try to connect families to resources. These are some aids for primary care. So the American Thoracic Society, these 2 things, these QR codes will bring you to these 2 handouts on oxygen therapy and what is interstitial lung disease. But even if you just Google ATS patient care handouts, oxygen, you'll find them. There is a registry for these kids in the US, and these are the sites geographically. This is, I think, one of your last questions. The 6-year-old you referred with asthma to a pulmonologist has been diagnosed with post-infectious bronchiolitis obliterans. Which of the following should you be prepared to discuss with the patient and their caregivers? Avoiding childhood vaccinations, isolation to prevent infections, need for limited activity, and potential need for supplemental oxygen therapy. So just in the interest of time, I'm going to go. So again, the potential need for supplemental oxygen therapy.
Okay, we're going to bring it home. So we need your help in these treatment strategies because these patients are going to see you more than they're going to see us. And all the kids are going to receive supportive therapy, looking at their oxygen status and their oxygen needs. Oxygen is the most common therapy, and nutrition, because we talked about nutritional failure and making sure they're growing well. Immunizations, this idea of mucus clearance, you can reinforce. Many of these kids may not get to us, specialized centers, because of social determinants of health or inequity issues. So the medical home becomes important with that. Anticipatory guidance for prognosis, talking to your pulmonologist, side effects from pharmacologic agents, genetic counseling. Again, you guys have to have the conversation with the family. Do you understand what the geneticist talked about? This is a genetic disease. I found that the medical home is so helpful in helping families understand that. And then understand, you just saw, there are national resource centers for ILD that if it's not near you, call one for your families. Oxygen is the most common. These are handouts that can be found on the internet. This was put together by families because families need to understand how kids could run around, have their oxygen tubing. Can be a lot of morbidity and a lot of quality of life issues. So it's important. We have off-label treatment that experts have found to be anecdotally improved. You can see the list here. They're not without side effects, including immunosuppressants and steroids. So helping us look at side effects for these, making sure that the children stay on these because stopping them can also be an issue. And then the good news, this is another thing to think about. We now have new therapy for pulmonary fibrosis that's coming forward. So it used to be that you had these diagnoses and people say, well, who cares? We can't treat it anyway. But that's changing. We are finding therapies. So having you help us with the diagnosis, getting these kids forward becomes important. This was a paper published looking at the impact of a drug in the adult population that could potentially be helpful for kids. So bringing it home before the end, key messages that your pediatricians, you can provide medical homes, and it's so important for these families. These disorders are rare, but you will see them, and the average time for diagnosis is like 5 years. So the more we can have you recognize it and low threshold to refer, it can help families. It can present at any age. Diagnostic cause, pathophysiology all become important. We've talked about evaluations. Multidisciplinary team's important, and you're really the manager of that multidisciplinary team with the families. You serve a vital role for these patients.